whereas laterally by the thyroid lobes and the carotid sheath contents, which is the common carotid artery, internal jugular vein, and the vagus. The pretracheal fascia, it extends to the pericardium, while the prevertebral fascia extends to the diaphragm. This from the thoracic inlet to the diaphragmatic hiatus, which is from the T7 vertebra, esophageal groove, and by the inferior thyroid artery. Whereas posteriorly by the C6, C7 vertebra, tracheal fascia, and the recurrent laryngeal nerve in the tracheoesophageal groove, and by the inferior thyroid artery. Whereas posteriorly by the C6, C7 vertebra, prevertebral fascia, and creating a retroesophageal space. Whereas laterally by the thyroid lobes and the carotid sheath contents, which is the common carotid artery, internal jugular vein, and the vagus. The pretracheal fascia, it extends to the pericardium, while the prevertebral fascia extends to the diaphragm. This connects the compartments in the neck and the chest. That's the reason it allows the infections from the tonsillar or the dental abscess to spread to the mediastinum easily.
So,
Arterial blood supply, it is
somebody is saying the slides are not visible.
checking in my other phone also, sir. It is visible to me.
It's okay with us. Okay, carry on. Maybe there.
Arterial blood.
Mm.
Arterial blood supply. It is supplied by the right and left superior and inferior thyroid arteries and the smaller branches from the common carotid and the subclavian arteries. Venous drainage is by the inferior thyroid vein. In this, the middle thyroid vein crosses from the internal jugular vein to the thyroid gland, and it is often divided to improve the exposure for the cervical esophagus during a surgical procedure. Nerve supply, recurrent laryngeal nerves, and the sympathetic chains. Thoracic esophagus, it extends from the thoracic inlet to the diaphragmatic hiatus, which is from the T7 vertebra. At the level of T7 vertebra, it shifts to the right. So the best approach to approach for a mid-esophagus is through the right thoracotomy or thoracoscopy. For example, during an Avery-Lewis or a minimal invasive three-hole esophagectomy. Distally, it again curves to the left after passing through the diaphragmatic pleura. So the best approach for the distal esophagus is through the left side. On the right side picture, it shows the relations of the thoracic esophagus in the proximal part of the thoracic esophagus. The anterior and lateral relations. Anteriorly, it is by the bifurcation of the trachea, the right pulmonary trunk, the left principal bronchus, and the azygous vein. Whereas the posteriorly, it is by the arch of aorta, descending thoracic aorta, hemiazygous vein, the thoracic duct, and the right vagus nerve, and the right lung in the pleura, and the right posterior intercostal artery. It is supplied by the bronchial arteries, one on the right side and two on the left branches, and from the DTA between T6 to T9 vertebra. It has a vast network of collateral vessels within the wall of the esophagus, allowing the esophagus to receive blood supply from larger vessels, perfusing other organs such as the thyroid, trachea, and stomach. Because of this rich intramural network of vessels, the esophagus can be completely mobilized from the stomach to the aortic arch, yet continue to be well perfused. And venous supply is by the azygous, hemiazygous veins, and the bronchial veins. The abdominal esophagus, it extends from the esophageal opening in the diaphragm to the cardiac end of the stomach. Anteriorly, it is by the posterior surface of the left lobe of the liver and the left gastric nerve. Posteriorly, it is related to the left crust of the diaphragm and the right gastric nerve. The blood supply is by the left gastric artery and the left inferior phrenic artery, and the venous supply is by the hemiazygous vein and the left gastric vein. The microscopic appearance of the esophagus, it has a mucosa, which has three parts: epithelium, which is stratified squamous epithelium; lamina propria, which contains the mucosal glands; and the muscular mucosa, which has only smooth muscle cell, which is inner circular and the outer longitudinal in arrangement. The longitudinal layer, it arises from the cricoid cartilage as two muscle bundles that converges 3 centimeters distal to the cricopharyngeus muscle and leaving a V-shaped weakened area posteriorly, which is covered only with circular muscle fibers known as Lamers triangle. This is a picture showing the Lamers triangle between the cricopharyngeus muscle and the esophagus. The next layer is the submucosa, which contains the mucous esophageal glands. The third layer is the muscular layer, which consists of the upper one third of the esophagus is with a skeletal muscle. The mid one third is both the skeletal and the smooth muscle, whereas lower one third is only smooth muscle. And the fibrous adventitia. There is no serosa layer in the esophagus. Physiology, the upper esophageal sphincter, it plays an important role in the swallowing process. It is comprised of cricoid cartilage at the ventral border and cricopharyngeal muscle towards its lateral and posterior borders. This pressure is due to the asymmetric creation of the structure. The phalanx has three phases. One is the oral phase, pharyngeal phase, and the esophageal phase. The oral phase is by the formation of the bolus, which is performed by the soft palate and the posterior aspect of the tongue. Then the second component comes is the upward movement of the soft palate towards the hard palate so that it closes the nasopharynx and the upward swing of the hyoid bone more ventrally, larynx and cricoid anteriorly and upward, thus allowing the epiglottis to flip downward and close the airways. This is the image showing the swallowing process. Initially, the bolus is formed. The second picture shows the closure of the nasopharynx by the upward movement of the soft palate and the downward movement of the hyoid bone. In the pharyngeal phase, this begins once the bolus passes through the glossopalatal opening. This phase begins, and this sequence is involuntary. The pharyngeal constrictional muscles contract, and the upper esophageal sphincter is opened by approximately 1 second of relaxation time. Then the bolus leaves the esopharyngeal area, moves through the hypopharynx and into the esophagus. Then comes the esophageal phase, which begins as the bolus enters the proximal esophagus through the open cricopharyngeal sphincter. The peristaltic contractions take over propulsion of the bolus and assist gravity in transporting the bolus through the esophageal corpus. Finally, all the structures return to the resting positions and all the airways open again as the upper esophageal sphincter closes. The primary peristalsis is when it is triggered by the swallowing center in the brainstem, and it has a contraction wave travel of at the speed of 2 centimeters per second. And it has a resting pressure of 20 to 60 mm of Hg, and the wave usually reaches the stomach by in 8 to 10 seconds. The secondary peristalsis, it occurs only when the primary peristalsis has failed and there is retained bolus in the esophagus. Its role is clear the esophagus from the retained bolus. Whereas peristalsis is a pathological condition. It is non-propulsive and uncoordinated, and their non-peristaltic nature means they move the bolus up as well as the down the esophagus. They are seen as intermittent ripples along the wall of the esophagus, lasting only a few seconds as multiple contractions rings or a segmented barium column producing a corkscrew appearance in the diffuse esophageal spasms. The diagnostic tools for esophageal pathologies is endoscopy, functional lumen image probing, high resolution esophageal manometry, and barium esophagus with barium tablet. In endoscopy, the esophagogastroduodenoscopy is a requisite in the evaluation of patients with suspected esophageal dysmotility because it can directly enable the mucosal visualization and exclude a benign conditions like stricture, hiatal hernia, or esophagitis, or any malignant conditions that can lead to motility disorders. Endoscopy also allows the delivery of therapeutics with esophageal dilatation when stricture is encountered. Findings of retained saliva or liquid in the esophageal lumen, along with a puckered lower esophageal sphincter and longitudinal superficial wrinkles or esophageal mucosa showing a pine strip mucosa, are generally suggestive of major esophageal disorders, motility disorders, and usually found around 41 to 91% of patients with achalasia. The second one is a functional lumen image probing. It is the newest Food and Drug Administration approved diagnostic tool to assess the esophageal physiology and is still in clinically earlier phases. The flip catheter includes a distensible balloon encasing multiple pairs of impedance sensors and a single distal pressure sensor. During a sedated upper GI endoscopy, and the flip catheter is passed transorally such that the balloon transfers the esophagogastric junction. Then the balloon is distended with a conductive aid through a mechanical pump. The flip system converts the readings into a three-dimensional rendering of the esophageal lumen in real time and measures the relationships between the cross-sectional area over the distensive pressure to generate a luminal distensibility. The most recent Flip version 2.0 or Flip topography converts the recordings to color-coded luminal diameter plots, enabling evaluation of distensibility across the esophagogastric junction, as well as the contractile response to distension in the esophageal body. From the healthy volunteer, the data it suggests that normal esophageal gastric junction distensibility index is more than 2.8 millimeters square per mm of Hg, and the normal diameter is 13 mm. If it is less than 2 mm square per mm of Hg, it is considered definitely abnormal, whereas a diameter of less than 13 mm is considered abnormal, and can serve as a supportive measure when esophagogastric junction or distensibility index is is considered indeterminate when between 2 to 3. It has been shown to predict treatment outcomes and have a role in tailoring foregut interventions such as peroral endoscopic myotomy or laparoscopic Heller's myotomy. This is the pictures showing the distensibility index between the antrum, pylorus, and the duodenum where the balloon is passed. And here, the distensibility index, the per square meter area is calculated. Barium esophagogram. This is the radiographic image which is recorded after ingestion of the barium contrast to assess the bolus transport through the esophagus into the gastric lumen, and has remained an important adjunctive during diagnostic modality in patients with dysphagia. It can identify any structural lesions such as strictures, neoplasms, or hiatal hernia, but can also identify some major motility disorders such as atlasia or diffuse esophageal spasm. However, overall sensitivity of barium esophagogram for motility disorders is fairly limited. It is usually from 56 to 69%. Addition of 13 mm barium tablet to the esophagogram protocol, along with the evaluation of esophageal MTE at 1, 2, and 5 minutes, can increase the sensitivity and also used to monitor treatment responses in esophagogastric junction outlet obstruction. This is the picture showing the post-barium contrast at 1, 2, and 5 minutes uh, with the passage of the bolus and decreasing in the length of the contrast. It can also show classic findings of a dilated esophagus, such as bird beak appearance in a achalasia or a corkscrew appearance in a diffuse esophageal spasm, nutcracker esophagus. Usually, a barium column empties completely in normal subjects at 1 minute and in all by 5 minutes. Hence, barium column height of more than 5 mm at 1 minute and more than 2 centimeter at 5 minutes should be suggestive of an outlet obstruction and can provide valuable complementary information in patients with manometric diagnosis of esophagogastric junction outlet obstruction. High resolution manometry, it is well established diagnostic tool that evaluates esophageal motility. It usually measures the dynamic intraluminal pressure changes in the esophagus by using closely spaced sensors. The Chicago classification is mainly based on the high resolution manometry findings, and it aims at defining the esophageal motility disorders. Uh, Procedure generally should be kept fasting for 4 hours. After that, the patient is kept in supine position. Following that, a catheter is placed. And a minimum of 60 seconds, quiet rest should be required for the adaptation period. And following this, the catheter position is confirmed with a minimum of 3 deep inspirations. Next, a baseline period of around 30 seconds is captured to enable identification of anatomical landmarks, including the upper esophageal sphincter, the lower esophageal sphincter, the respiratory inversion point, and the basal esophagogastric junction pressure. This is performed by giving 10 times 5 ml wet swallows of a normal ambient temperature, water, or saline. Uh, and there should be at least 30 seconds gap between each swallow to avoid any effects of deglutition inhibition. Finally, one multiple rapid swallow sequence is performed, which is five times 2 ml wet swallows administered using a 10 ml syringe, which is 2 to 3 seconds apart, which can be repeated maximum up to 3 times if there is any failed attempt or an abnormal contractile response. Then the patient position is changed to upright position, usually sitting at 80 degrees or higher with legs hanging out offside of the bed, but not hunched or leaning over. In this, at least 5 times 5 ml wet swallows are performed, and similarly 30 seconds gap should be present between each swallow. Finally, one rapid drink challenge with 200 ml is ingested as fast as possible through a straw. After the high resolution manometry, if there is no conclusive evidence of major motility disorders, then additional HRM supportive measures can be considered, which are solid test swallows and solid test mean. If there is equivocal response, then or it doesn't fulfill the criteria of an achalasia, then a timed barium esophagogram, preferably with a tablet, or endoluminal functional image probing should be done. On the right side, this is a picture of a high resolution manometer. Uh, this shows the on the y-axis on the left side. One second. On the y-axis on the left side is the pressure and the length of the esophagus. On the x-axis is the timing of the uh, swallowing is the time axis basically. On the as corresponds to the length, the upper part is the upper esophageal sphincter, and the gap between the upper there is a gap between the yellow and the red margin. This indicates the upper esophageal sphincter relaxation period. And next comes is the swallow, which is in the proximal part of the esophagus. And then there is a small break in the continuity, which is green in color. That indicates a transition phase between the striated muscle, which is in the proximal, and with a mixed muscle in the mid part of the esophagus. And in the mid part of the esophagus, you can see a color grading, which is from yellow to pink. This indicates that the pressure gradient is between 40 to 70 mm of Hg in the mid part of the esophagus. And the next comes is the distal part of the esophagus. Here, distal part of the esophagus. Here, also the pressure gradients are between uh, 40 to 80 mm of Hg. And these segments are called the clause segments. And the lower part, there is LOS, which is mentioned as the lower esophageal sphincter. And there is a break between the contraction phase and the lower esophageal sphincter. That is called as the lower esophageal sphincter relaxation period. In this HRM matrix, what we normally study is the integrated relaxation pressure, which is nothing but the lower esophageal sphincter relaxation period. If the higher, if there is high integrated relaxation pressures, that means there is impaired relaxation. Example, in case of an achalasia cardia. Here you can see on the graph that the low integrated relaxation pressure is measured between the y-axis and the distal contractile part. Now, normal pressure should be less than 15 mm of Hg. Then next comes is the distal contractile integral, which quantifies the strength and vigor of esophageal contractions, which is through that is nothing but the peristaltic contractions. If it is high, then it is a hypercontractile jackhammer esophagus. If it is low, it indicates a weak or failed peristalsis. It should normally be between 450 to 8,000. And next is the distal latency. It is nothing but it measures the timing of contractions. If it is whether it's premature contractions or late contractions. If it is a premature contraction and it is a distal esophageal spasm. Normal, the contraction period should be more than 4.5 seconds. The integrated relaxation pressure assesses the adequacy of swallow-induced lower esophageal sphincter relaxation and is defined by the mean of median 4-second nadir of the total esophageal pressure in the 10-second swallow period. That means the maximum at 4 seconds is taken. If it is normal median, IRP suggests there is adequate relaxation and it rules out any disorders of the esophageal gastric junction. It differs from patient to patient in sitting position and upright position. In a supine position, it is less than 15 mm. In an upright position, it is less than 12 mm, which is considered as normal. And on the other hand, if it is less than 22 mm in upright and is less than 15 mm, is considered in case of other system. Basically, with different systems, the border values changes. In a Medtronic system, it is 15 mm of Hg, whereas in a Labori or diverse stick, it is 22 mm of Hg. Uh, distal contractile index. It's a three-dimensional metric. It is to assess the contraction vigor of the esophageal smooth muscles by taking the length, amplitude, and duration of contractions into consideration. So it is normally between 450 to 8,000. And if it is hypercontractile swallow, it is more than 8,000. If it is weak contraction, it is 100 and or 100 to less than 450. And if it is a failed peristalsis, it is less than 100 mm per mercury per second. Distal latency, which is nothing but the time interval between the upper esophageal sphincter relaxation to the contractile deceleration point of the peristaltic wave in the distal esophagus. The contractile distal deceleration point is nothing but in the distal esophageal contraction period, there is a dip in the there is a change in the motility. Means the speed of the contractions changes between the mid and the distal part of the esophagus. That point is called as the contractile deceleration point. It can help differentiate between a premature, which is less than 4.6 seconds, versus a peristaltic contraction. Sometimes a provocative maneuver, such as multiple rapid swallows in the supine position and a rapid drink challenge in the upright position, it might increase the diagnostic sensitivity and specificity. In the recent updated Chicago classification version 4.4, it includes these manuals in the standardized protocol for all patients undergoing HRM study because they can provide supporting data regarding outflow obstruction across the junction. And it also provides an assessment of peristaltic reserve in the setting of an ineffective esophageal motility. Hence, it should be applied. This applicability is to individualized to every patient. And further studies are needed to determine if universal application of these manuals leads to change in clinical outcomes. This is a normal healthy subject showing the distal contractility index in the supine and the upright. In the supine, you can see the contraction is more, which is 1822 mm of Hg, which is the distal contractile index. Whereas in an upright position, it is 906 mm of mercury. The second. In this is a comparison between a Chicago classification version 4.4 for it has disorders of esophageal gastric junction outflow and disorders of peristalsis. In disorders of outflow obstructions, there should be an elevated median integrated relaxation pressures, and it is of type 1 achalasia, type 2 achalasia, type 3 achalasia, and outflow obstructions. In case of a peristalsis, the integrated relaxation pressures are usually normal. These are absent contractility, diffuse esophageal spasm, hypercontractile esophagus, and ineffective esophageal motility. Disorders of outflow obstruction. In definition in a third version versus fourth version is that the difference is only integrated relaxation pressures are elevated both in supine position and an upright position. And there is a 100% failed peristalsis in type 1 achalasia. In type 2 achalasia, the IRP is elevated as well as there is 100% failed peristalsis and there is more than 20% of pan-esophageal pressurization. And in type 3 achalasia, raised IRP with an 100% absent peristalsis and more than 20% swallows with spasm. In outflow obstructions, there is raised elevated IRPs in both supine and upright position. In supine, intrabolus pressure is elevated. There is normal peristalsis, dysphagia, and or non-cardiac chest pain, and it is usually confirmed with non-HRM supportive test. In esophageal, in absent contractility, IRPs are normal, but there is 100% failed peristalsis. In diffuse esophageal spasm, the IRP is normal with more than 20% swallows with spasm, usually present with dysphagia or non-cardiac chest pain. In a hypercontractile esophagus, more than 20% hypercontractile swallows are present with normal IRPs, usually present with dysphagia or non-cardiac chest pain. In ineffective esophageal motility, more than 70% is ineffective or fragmented swallows or more than 50% failed swallows. Uh, Chicago classification version 4.4, it resumes of the change. It resume of the changes is manometric and non-manometric evaluation is required to arrive at a diagnosis of obstruction, outlet obstruction. And in case of outlet obstruction, diffuse esophageal spasm and hypercontractile esophagus, this must be accompanied by a obstructive esophageal symptoms. And the manometric protocol should be ideally include supine and upright positions. And ineffective esophageal motility is more stringent and now encompasses fragmented peristalsis. In Chicago classification version 3, the fragmented peristalsis was a separate point, but in a version 4, it is included with ineffective esophageal motility. This is the summary of whatever I have explained right now. This abnormal integrated relaxation pressure with absent peristalsis If there is 100% absent peristalsis, it is achalasia. And if the peristalsis is preserved with an abnormal IRP in second position, then you have to confirm with a timed barium esophagogram or a flip scan, which indicates outlet obstructions. And in case of a normal IRP, which comes the diffuse esophageal motility, hypercontractile esophagus, and absent contractility. This is the high pressure manometry diagrams showing the type 1 achalasia where there you can see there is no contractility along the length of the esophagus. That indicates there is failed contraction completely. In type 2, you can see the green bars, which indicates the pan-esophageal pressurization. In type 3, there is only hypercontractile part in the distal part of the esophagus. That is the distal contractile part. In type D image, outlet obstruction, the contractile part, the esophageal length, timing is delayed. Whereas in image, there is absent contractility with 100% failed peristalsis, but you can see the normal esophageal relaxation phase, which is the break in the green bar on the x-axis. In F image, you can see the diffuse esophageal spasm. Normally, here it is not mentioned, but the esophageal sphincter relaxation is very less, so that the timing of distal contractile esophagus is less than 4.5 seconds, which shows a premature contraction. In type G, the hypercontractile esophagus, you can see the distal part of the esophagus, it has an expanded point version towards the x-axis, that indicates there is a distal contractility index is higher and it is more than 8,000 mm of Hg. And in H, you can see there is a faint contractility along the length of the esophagus, which is the ineffective esophageal motility. These are the diagnostic investigations of the same thing which I have explained before. Motility disorders according to Chicago classification 4, achalasia, diffuse esophageal spasm, hypercontractile esophagus or the jackhammer esophagus, and ineffective esophageal motility. Achalasia cardia, it represents a classic esophageal motility disorder and it occurs due to selective loss of inhibitory neurons in the myenteric plexus of the distal esophagus and the lower esophageal sphincter, resulting in a neuronal impedance and unopposed excitatory activity and localized decrease of inhibitory activity that is resulting in failure of lower esophageal sphincter relaxation and disrupted esophageal peristalsis. Its incidence is usually 1 in 1 lakh people. It is a pre-malignant condition with 8% chance of conversion of malignancy over a 20-year period. Usually presents with dysphagia, initially with to solids than to liquids, but usually present with both. Chest pain, regurgitation of the foul-smelling food because of the retention, and weight loss. They usually have postprandial coughing or nocturnal coughing. Long-standing achalasia can lead to pneumonia, lung abscess, or bronchiectasis. Staging based on the dilatation of the proximal esophagus. The proximal dilatation is less than 4 centimeters, stage 1. It is between 4 to 6 centimeters, stage 2. If it is more than 6 centimeters, then it is stage 3. And it is sigmoid dilatation if it is more than 10 centimeters. And according to the clinical scoring, if there is no weight loss or dysphagia or retrosternal pain or regurgitation, it is 1. If if there is weight loss of less than 5 kgs with occasional dysphagia and other retrosternal pain or regurgitation. If it is between 5 to 10 kgs with daily symptoms and with more than 10 kgs with daily symptoms during each meal, retrosternal pain several times a day. The main investigation it is diagnostic investigation, barium swallow. It shows a bird beak appearance due to constriction of the lower esophageal sphincter and dilated proximal esophagus. And usually the chest X-ray shows a mediastinal widening with a double contour. On the right side, you can see the expansion of right parasternal. You can see the esophageal shadow. And there is anterior tracheal bowing. And there is air fluid level in the mediastinum and small or absent gastric air bubble. The gold standard is a manometry. It has an elevated integrated relaxation pressures and absent peristalsis. There are 3 types. Type 1, as explained before, 100% failed peristalsis with no pressurization. Type 2 is 100% failed peristalsis with pan-esophageal pressurization for at least more than 20% of the phallus. And the type 3 is distal has a premature contractions for at least more than 20% of the phallus. These are the pictures showing similar thing. There is no pressurization or the esophageal bars. There is 100% absent peristalsis. In type 2, there is pan-esophageal pressurization, which are indicated by the green bars. And the integrated relaxation pressures you can see measured as a 24 mm of Hg. Whereas in type 3, you can see there DL 3.1 seconds, which indicates that there is a premature spastic contraction. Endoscopy is done to see check for the mucosa in case of any esophagitis or a cancer. Management is generally in a case of high surgical risk patients, a botulinum toxin injection is done. If it is successful, then a repeat therapy is proceeded. If it is failed, then a pharmacotherapy with nitrates, calcium channel blockers is done. In a low surgical risk candidates, if it is less than 45 years of age, consider a myotomy first. If it has failed, then a repeat pneumatic dilatation, myotomy, or esophagectomy is performed. If it is more than 45 years, then consider a graded pneumatic dilatation first. If it is successful, then repeat. The similar thing, medical management with sublingual nitrates or calcium channel blockers is performed. It is usually a bridge to effective treatment or non-surgical candidates and failed botulinum toxin injection patients. Botulinum toxin injection it is nothing but a neurotoxin that inhibits the release of acetylcholine from the nerve terminal, thus blocking the neurogenic but not the myogenic component of the lower esophageal sphincter tone. It is injected into the lower esophageal sphincter endoscopically by a sclerotherapy needle at a total dose of 100 units and usually divided into 4 aliquots and injected into the 4 quadrants of the lower esophageal sphincter, just above the squamocolumnar junction. It is considered in patients who are unsuitable and more risky and have more risky for interventions. The second comes pneumatic dilatation with either a Buki, plumber pneumatic, or a Nagus hydrostatic dilators. The predictors are age more than 40-45 years, female gender, lower esophageal sphincter should be less than 10 mm of Hg following pneumatic dilatation, and narrow esophagus prior to pneumatic dilatation, and type 2 pattern on HRA. If the PD is performed usually with a non-radio opaque graded sizes, it also comes in 3 sizes, 3, 3.5, and 4 centimeters, and usually used in a graded fashion with starting with a 3 centimeter buji. This usually can be performed either with a fluoroscopy or a non or without fluoroscopy. If performed with a fluoroscopy, the control is aided with the guide wire and it is inflated with air to forcefully stretch the lower esophageal sphincter muscle, and it should be held for 10 to 15 seconds. You can see in the image, the pneumatic dilator is passed into the lower esophageal sphincter. The balloon is inserted and inflated and for expanding the lower esophageal sphincter, and the inflated balloon should be kept for 10 to 15 seconds, then removed. Then this should generally follow up with a gastrographin or a barium study to evaluate for any esophageal perforation. And it should be reviewed after 4 to 6 weeks based on symptoms and radiograph repeat dilatation. With a larger balloon is performed in case of a failed response. And usually graded dilatation is safer with a lesser risk of perforation of less than 1%. The other thing is esophageal stents. It is used in high risk patients, but is very less tested and high risk of morbidity and migration risk. Usually, a bare metal stent is kept in place for 6 to 30 days and is removed, and usually a length of 20 to 30 mm is preferred. Surgical aspect, modified Heller's cardiomyotomy with a fundoplication is usually preferred. It can be partial fundoplication or a total fundoplication depending upon the GERD. uh, or it can be open approach or a thoracic approach. It can be laparoscopic approach, radio assisted approach. And one more procedure is the paroral endoscopic myotomy. Heller's myotomy, it was first described by Heller in 1930. Laparoscopic Heller's myotomy with partial, usually performed under general anesthesia. The position is the reverse Trendelenburg position with the legs split. You can see the image on the right side with the first assistant, and second assistant standing on the right and left and right hand side with the main surgeon standing in between the legs. The port placement, you can see the image here. There is one port for camera, one for the surgeon's right hand, then one for the surgeon's left hand to dissect around the esophagus, which is third mentioned in the around the esophageal sphincter. On the right hand, it is to hold the esophagus. Whereas fifth port below the zippy, below the rib cage, it indicates it is for the assistant to retract the liver. And the assistant port is present for retraction, that is 4. Port dissection, the steps in a Heller's myotomy are first dissection. The dissection depends on the type of fundoplication that is planned. Generally, to prepare for myotomy and posterior partial fundoplication, the stomach must be mobilized and the hiatus should be completely dissected. And the assistant usually retracts the gastroesophageal fat pad inferiorly to reduce any hiatal hernia, and the surgeon then divides the gastroesophageal ligament to expose the right crus. Then mediastinum is then entered anteriorly, and the esophagus is mobilized circumferentially. The short gastric arteries are divided to expose the esophagus for myotomy. The gastroesophageal fat pad is removed, and care should be taken to protect the left vagus nerve because it lies in the gastroesophageal fat pad. You can see the yellow structure on the picture shown below, and you can see the gastric fundus is pulled down to expose the gastroesophageal fat pad. Then second step is the myotomy. Usually a bougie is inserted transorally. It creates a tension around the circular muscles. This facilitated by better myotomy. After mobilizing the esophagus, the myotomy is initiated usually around 2 centimeters above the gastroesophageal junction. Initially, the longitudinal muscle fibers are cut and then followed by the circular muscle fibers. And following the division of circular muscle fibers, the moment you are going in, you will generally feel a taut muscle structure. After dividing that, the mucosa usually bulges out. With the help of the grasper, the myotomy edges are usually elevated, and the submucosal plane is created by blunt dissection to further facilitate the proximal myotomy. While doing the proximal myotomy, the esophagus is usually pulled down to prevent injury to the crura. And it should generally be done 4 to 5 centimeter onto the esophagus. And you should not go beyond that because of the risk of formation of diverticulum in the future. After esophageal myotomy, you proceed with the gastric myotomy, which is usually performed for 2 to 3 centimeters on the distal gas fundus. After completing the myotomy, the muscle edges are mobilized laterally to each side to better expose the submucosa. Any remaining circular muscle fibers are divided and a bougie is removed. An endoscope should be used to evaluate the myotomy and perform an air leak test. This is the similar thing showing the myotomy. Initially it is started 2 centimeters above the gastroesophageal tension, proceeded downwards. Initially the longitudinal muscle fibers are cut, followed by the circular muscle fibers. Then the submucosa usually bulges out. Once the submucosa bulges out, the plane is created and the further circular muscle fibers are dissected and the patency is measured with an endoscopy, and air leak test is also performed to see for any perforations. This is followed by a fundoplication. This is usually performed to prevent any post-op GERD. There are 3 types of fundoplications. One is Nissen's, which is the 360-degree fundoplication. The second one is Toppet, which is posterior 270-degree fundoplication. And third one is a DOR, which is anterior 180-degree. In a Nissen fundoplication, generally the right and left crura are reapproximated posteriorly using 2 or 3 heavy silk zero permanent sutures. Uh, then second thing is the preparation of the wrap. Generally creation of the orogastric tube should be replaced with a 52 to 60 French boogie. Then a marking stitch is placed on the posterior fundus. The stitch is done by grasping the greater curvature of the stomach and it is reflected to the right side so that the posterior fundus is exposed properly. Once the suture is placed, 3 centimeter, generally the suture should be placed 3 centimeters distal to the gastroesophageal junction and 2 centimeters from the part which we grasp the greater curvature. Then you create a wrap around the posterior fundus is passed beyond the esophagus with a stitch we took and from the left to the right side. Then the anterior fundus is grabbed 2 centimeters from the greater curvature and 3 centimeters distal to the gastroesophageal junction. It is then brought to the front of the esophagus to join the posterior fundus. The anterior fundus is joined to the posterior fundus at the 10 o'clock position in the right side on the anterior aspect of the esophagus. Then the fundus is grasped anteriorly and posteriorly at a position equidistant from the greater curvature to avoid any incorporation of the gastric body into the wrap. That is to avoid post-op dysphagia. This the picture shows the wrapping of the esophagus around wrapping of the fundus around the esophagus. The greater curvature is held on the left side, and it is brought beyond the from behind the esophagus, the posterior fundus, and the one part of the and the anterior part of the esophagus is brought together to join the posterior esophagus, which is the third picture, and it is uh, joined. Both of them are joined to close the myotomy site. 3 to 4 seromuscular sutures are placed from left to right in three structures. First one is the anterior fundus. The second, and it is the most cephalad suture placed. The remaining sutures are placed sequentially to cover a total 3 centimeters of the intra-abdominal esophagus. The wrap is anchored as shown before. It also prevents, this used to prevent the distal migration around the gastric cardia. Topped esophagus, which is a posterior 270 degrees esophagus. It is similar to Nissan's posterior fundoplication, except that the anterior, the difference is that the anterior part of the fundus is not mobilized. And the posterior fundus is mobilized beyond the esophagus, and it is sutured behind. The door anterior procedure in this, here the right margin of the fundus is sutured to the left margin of the esophagus, and the front part of the fundus is sutured to the right margin of the esophagus. The second row is also sutured to the right crest. This is basically an anterior fundoplication. The greater curvature is brought anterior to the esophagus and sutured with the right crest of the diaphragm. In a post-op care, generally in a POD1, they give a water-soluble contrast esophagogram to exclude any perforation or obstruction, and it is followed up for 14 days by a purine diet, and then a regular diet is resolved. Usually 3 to 4 weeks post-operatively, a regular visit is planned with endoscopy, timed barium swallow, and pH testing. And it is planned regular after 6 months to evaluate for GERD. Due to increased risk of squamous cell carcinoma, screening endoscopies are recommended every 5 years. The next procedure is peroral endoscopic myotomy. In this, the inner circular muscle layer of the lower esophageal sphincter is cut through a submucosal tunnel. Indications are achalasia cardia, nutcracker esophagus, distal esophageal spasm. And contraindication is in case of an extremely extensive well fibrosis is present around the esophageal wall. This has 5 steps. One is the endoscopic measurements. In this, the short overtube is used, exception to when a long endoscopic myotomy is required, the short overtube is not used. This stabilizes the endoscope, basically, and it reduces, and it results in a less tension in mucosotomy. It is, in case of a type 1 and type 2 achalasia, a short myotomy is performed, whereas in case of type 3 achalasia, a long myotomy is performed. Second step is the saline lift and mucosotomy. The site of mucosal incision should be 3 to 4 centimeters proximal to the site of myotomy. And a lifting solution with 1 ml of methylene blue plus 500 ml of NS with less than or equal to 1:1000 adrenaline is injected. This lifts the mucosa. And with this is usually injected with a 23 gauge endoscopic injection needle. 1.5 centimeter mucosotomy is performed using hook or triangle tip cautery. Then the third step is the submucosal tunneling. The endoscope is inserted through the mucosotomy and the submucosal plane, and the hydrostatic dissection can be performed instilling the lifting solution. The mucosa and submucosa are separated from the circular fibers using cautery. The large bridging veins are occasionally encountered, which are managed by cautery, and difficult bleeding can be controlled by direct pressure by dissecting the cap. During mucosal tunneling, care must be taken to avoid mucosal injury from cautery and shear stress injury from the endoscope. On the right side, you can see the endoscope is passed And in below, you can see the methylene blue injection with which is lifting the esophagus, followed by which the endoscope is passed through the mucosotomy, and it is passed through the mucosotomy in the submucosal plane till the lower esophageal sphincter. Then, after reaching the lower esophageal sphincter, a circular myotomy is performed. It also begins 2 to 3 centimeters distal to the opening, that is the mucosotomy. Then the circular muscle fibers are divided using endocut current by triangle tip or hook artery. Once the fibers are divided, the longitudinal fibers are easily visible. The plane between the longitudinal and the circular fibers is followed distally with continued myotomy, and it should be continued well into the stomach wall. Then the closure of the mucosotomy. Once adequate distribution is achieved, the mucosotomy is closed using clips or endoscopic sutures. Any mucosal perforations to be closed first. Then mucosotomy closure is done distal to the proximal. Uh, Other disorders of the esophageal peristalsis, these are spastic motor disorders. This disordered esophageal motor function can be due to either hyperactivity such that peristalsis is premature or contractile vigor is increased. The primary symptoms are dysphagia and non-cardiac chest pain and are often accompanied by heartburn and regurgitation. On HRM, two groups of spastic esophageal disorders are present. One is distal esophageal spasm, one is hypercontractile esophagus. In distal esophageal spasm, it is characterized by premature contractions in 20% or more swallows. On manometry, in the setting of intact deglutative relaxation with a normal integrated relaxation pressure. The premature contractions are defined by the distal latency of less than 4.5 seconds, or in the setting of a distal contractile index of 450 mm of Hc or greater. The greater the number of premature swallows on HRM, the greater the confidence in the distal esophageal spasm diagnosis. A manometric diagnosis of esophageal spasm can be supported by lack of peristaltic inhibition during resolution manometry, or abnormal contraction with stress of a bolus load. Importantly, true primary diffuse esophageal spasm is rare, and when identified, is considered along the spectrum of type 3 achalasia cardia. Timed barium esophageal spasm helps in the supportive and diagnosis of diffuse esophageal spasm. It shows a corkscrew appearance or a rosary bead appearance on the barium meal esophagogram. Retention of the barium during esophagogram is an important distinction between the diffuse esophageal spasm and an achalasia diagnosis. The other part is the hypercontractile esophagus. In this, on the HRM, it has more than 20% or more swallows with hypercontractility, with a contractility index of more than 8,000, with a normal integrated relaxation pressures. This is normally termed as a jackhammer esophagus. The term jackhammer esophagus is no longer synonymous with hypercontractile esophagus. To make a conclusive manometric diagnosis of hypercontractile esophagus, criteria for achalasia and diffuse esophageal spasm must not be met, and underlying outlet obstruction should be excluded. The supportive findings for hypercontractile esophagus includes intrabolus pressurization, abnormal patterns with RDC or rapid swallows, or absence peristaltic reserve on multiple rapid swallows. A multitude of manometric patterns can meet the criteria of hypercontractile esophagus over jackhammer esophagus with repetitive prolonged contractions, the later considered to portend greater pathological significance. This shows the diffuse contractile esophagus, and the violet part in the center indicates that it is of higher pressure, and the latency is more. And you can see there is no break in the lower esophageal sphincter relaxation. Hypomotility disorders, ineffective esophageal motility. The manometric diagnosis has evolved over time and now require more than 70% of ineffective swallows with the contractility index of 100 to less than 450, or at least 50% failed peristalsis with contractility index of less than 100 mm of mercury. This might affect the decision making before anti-reflux surgery due to risk of post-operative dysphagia. Although some studies show similar outcomes with after a partial or Nissen's fundoplication. Provocative mania such as multiple traffic swallows might identify contractile reserve in this group of patients, and it predicts the risk of post-operative dysphagia with a sensitivity and specificity of 67 and 64% respectively. Presence of ineffective esophageal motility and findings on MRS are alter the type of fundoplication that is to be offered to the patient. A minimum of three MRS sequences should be performed to demonstrate adequate contraction reserve. In contrary to surgical fundoplication, it should be noted that IEM is a relative contract indication for magnetic sphincter augmentation because esophageal peristalsis is necessary to distend the magnetic band and allow the bolus to enter the stomach. First picture shows the intact swallow with a contractility index of 1285, which is normal. With the second one shows the ineffective swallow with a gap of between the primary swallow and the secondary swallow with a distal contractile index of around 500. The third one shows a distal contractility index of less than 450 with a ineffective with the peristalsis present, but which is very ineffective. Absent contractility, it is defined as 100% failed peristalsis with an index of less than 100 mm of mercury with a normal IRPs in both supine and upright positions. It is usually considered as a sclerodermal esophagus because of high prevalence in patients with connective tissue disorders. However, if dysphagia is a prominent symptom and the manometric evaluation shows a median in IRPs in supine position of around 10 mm of Hg, type 1 achalasia should be ruled out as a differential. This is the management options for peristaltic disorders. In case of a diffuse esophageal dysplasm, hypercontractile esophagus, ineffective motility, and absent contractility, evaluation should be done for underlying GERD. If the GERD is present, then a medical therapy to optimize by PPI is done and followed by a esophageal duodenoscopy with dilatation if dysphagia is present. If there is no GERD, but prominent symptoms like dysphagia is present, in case of a spastic disorders with dysphagia, esophageal duodenoscopy with dilatation with or without Botox injection is performed. If there is no improvement, then evaluate the emptying time with a barium esophagogram. If that is abnormal, then perform a pneumatic dilatation or a peroral esophageal myotomy. If the patient presents with a non-cardiac chest pain, in patients with spastic disorders, a smooth muscle relaxers can be given, or Botox injections, or neuromodulators, or behavioral treatments. And in case of hypomotility, neuromodulators or behavioral treatments are generally an option. If the patients with hypomotility disorders present with dysphagia, then usually advise a lifestyle modifications or esophageal duodenoscopy with dilatation is performed. Thank you, sir.
Okay, good, Navya. It is uh, because we don't discuss esophagus very often. Although your title was manometric studies, you touched upon most of the motility disorders. But before talking about it, there are certain things that you have to know about the peculiarities of the esophagus, which you missed totally. One is that the esophagus, as you rightly said, it has three segments: the cervical esophagus, the thoracic, and the abdominal esophagus. The importance of the abdominal esophagus is that there is some amount of esophagus within the abdomen, and there is an angulation with the esophagus and the GE junction, gastroesophageal junction. That is an important aspect, and it is the natural defense mechanism to prevent reflux of the acid into the esophagus. That is something that you should know, and that is known as the angle of Hill. Second, the diaphragmatic crura, which goes round as a pinch cork mechanism at the GE junction. And the third, the intraesophageal portion is subject to increased intra-abdominal pressure as compared to the negative pressure in the uh, chest. So it again aids the Pinchcock mechanism to prevent reflux. And finally is the lower esophageal sphincter. Now, before we talk about the other things, the peculiarities of esophagus is that it has got segmental blood supply. Second, the strongest layer of the esophagus is the submucosa. You must all remember that it is not the muscular part, it is the submucosa. That is why a hilar myotomy and all those things is effective. And third is that, there are certain dehiscences, or what you call uh, defects in the esophageal wall, which predisposes them to diverticular disease. The one is the Killian's dehiscence in the neck, and the other one is at the lower esophageal sphincter. And the after the submucosal this thing, the other thing that you have to know is the G junction we talked about, and the submucosal portion. Then when you're talking about the investigations, the one thing that you all must remember is that esophagus has got peristalsis. So when you do a barium swallow, and that too a dynamic barium swallow, as you are watching it, it goes in segments. You cannot see the entire esophagus in one frame. If you see the entire esophagus opacified in one frame, that means it is a pathological esophagus. So you must remember that. So you can never see a normal esophagus in complete esophagus in one frame. That is why you have to have multiple images as a dynamic study. Then coming to manometry, in the olden days, it was basically just the pressure measurement. But now, of course, the high resolution manometry has got a lot more information that can be deciphered. And it is a little confusing and difficult to understand on your first reading. You have to do this on repeated reading, and then you can understand the manometry. Although most of the time the manometry is followed by for medical management, rather than, and once the gastroenterologist decides that this patient is for surgery, then you can go ahead. So the interpretation of manometry is a little difficult. And then you talked about motility disorder. In dysphagia, the one important differentiation between a motility disorder like achalasia as against a stricture, a corrosive stricture, or even a malignant obstruction, is that in achalasia, the dysphagia is more to liquids first than solids, whereas it is the other way around. In the malignancy or corrosive stricture, it starts with solids and then progresses on to liquids as well. This, you must remember these things. In the surgical management of esophageal, motility of achalasia, actually, is the modified Heller was the gold standard. What is modified? In the original Heller operation, he divided these muscular layer in both the lateral aspects of the esophagus, whereas in modified, only one wall is divided, and up to the mucosa, so that the mucosa bulges out. Okay, and as we said earlier, the submucosa is the strongest layer, so it will hold. You have to make sure that you don't make a puncture in the submucosa. And the approaches are either abdominal or thoracic, and of course nowadays the robotic techniques have come. The importance of knowing this is that you should, when you do a myotomy, you should go up to the inferior pulmonary ligament on the top and to about 2 to 3 centimeters on across the GE junction. This is the complete myotomy. Otherwise, you will have recurrences. And to do go up to the inferior pulmonary ligament, I mean inferior pulmonary vein, it is up to the inferior pulmonary vein on the esophagus. So if you have to do that, a thoracic approach is much better than the laparoscopic or abdominal approach. So that you also have to know. And I mean, of course, then again you have to do corkscrew esophagus and diffuse spasm and all, or most often treated medically rather than surgically. And then, of course, you all also mentioned that achalasia is a pre-malignant condition, so you have to be careful. And then there is another pre-malignant condition which is called the Barrett's esophagus. So these two can give rise to CA of the esophagus in future. So you have to be treated. And again, an advanced stage of achalasia can cause severe distension of the proximal esophagus, can give rise to aspiration. Most of these patients die out of aspiration and aspiration pneumonia rather than just the achalasia or further things. So these are few things that you should. And then another important thing about esophagus is that it has no serosa. So whenever you do an anastomosis, it takes a while for the anastomosis to heal. Unlike in the intestines, the anastomosis is sealed within 48 hours because of the serosa in the gut, whereas esophagus is devoid of serosa, and that is why the leaks are more often in the esophageal anastomosis rather than the gut anastomosis. These are few things that you should know. Any other comments, sir?
No, same comments, because the examiners expect you to know that in anastomosis of esophagus, the most important thing is the mucosa and submucosa, because the opposition of these two is very important actually, because there is no serosa. That's why the infection and other things can spread easily to the mediastinum if there is a leak in the esophagus. And as Krishna said, we have been teaching for a long time that in achalasia cardia, the uh, dysphagia is to fluids first. And that the explanation we used to give is that the achalasia is a non-relaxation. So solids by the weight itself can find their way into the stomach, whereas in CA or in stricture, it's a solid dysphagia first, and the liquid comes and in carcinoma, at least till about 60% or 66% of the circumference is affected. The dysphagia doesn't occur. That's why diagnosis is always late. And we all used to do the uh, modified Hell's cardiomyotomy from the left thoracotomy. That's the best, because we used to teach that the incision should extend 6 centimeters onto the esophagus, 3 centimeters into the stomach. And then sometimes you have to combine it with fundoplication. Original fundoplication 360. The main problem with the Nissan fundoplication is, as in India, a lot of people have the habit of eating very much and then they have to belch. Then only they get the satisfaction. And once you do the Nissan fundoplication, you cannot belch, you cannot vomit. So there's the two main problems with Nissan. Then came the Tocket, which is about 270-degree plication of the stomach, and then the door, which is anterior plication of the stomach to reduce the reflex esophagitis, then I got the same objection when you do uh, modified hairless myotomy, either surgically from the abdomen alone or by laparoscopically. Probably, I think, much better to do by VATS, because you can extend it to any extent onto the chest. So and you can do all the fundoplications also with a uh, you can combine them with a thoracoscope and a laparoscope, so that is generally I got. Okay. What they do here, actually, esophagus is one subject which is neither the general surgeon nor the
Yeah,
thoracic surgeon
it's a,
want,
it's a,
because
it's a gray zone.
it's an orphan. So
It's a gray zone. Nobody wants to do the esophagus. And and actually, one of my consultants in the UK used to say that the esophagus is the worst organ to operate on. Almost 30 to 40% mortality because it used to choke around. Because he used to say, where is the soul of the body? So everybody thinks it's the heart or it's in the lung. No, you can replace the heart and lung, but if you operate on the esophagus, patient will die. So the soul of the body was in the esophagus. He used to joke around. Right. Esophagus is an important subject, especially for those of you who want to go beyond MCH or DNB. If you want to do some Western qualification, either USMLE or FRCS and other things, esophagus is important. This thing, almost 20 to 30% of your questions will be on esophagus. We used to do, I used to do a lot of esophagus in St. John's, along with my general surgery colleagues like Kilpadi and Kenneth and this thing. But now, after moving to Narayana, I stopped doing that.
and when you actually do a from the left chest, actually, you, you cut both layers of the muscle, and then you must see the mucosa bulging out. And actually, at that stage, this anesthetist passes a nasogastric tube and inflates it. Sometimes you find that you have left some muscle fiber which is still restricting the bulging of the mucosa. So you have to cut all of them so that the anesthetist inflates it. That makes sure there is no hole and also no muscle fiber is left bridging your mucosa from bulging out. That's very important step. Okay. All right. Thank
Okay.
you.
Any questions from anybody?
Okay.
All right.
Thank you.
The
Thank
other topics that you need to know in esophagus is one is motility disorder like achalasia. Second, management of perforation, either traumatic or iatrogenic. Third is CA esophagus, both which also includes the pre-malignant conditions like the Barrett's esophagus. And the fourth important thing is the management of corrosive strictures. So these are the topics that you should talk about. And the last one, which is very important, is the different conduits that are available for esophageal replacement, how and why and when you choose to do what. That is the ultimate, the last one that you should know. And then, of course, the complications of esophageal anastomosis and the placement of the esophageal replacement, whether it is in the posterior mediastinum, whether it is in the substernal or subcutaneous, this thing. So these are all the pros and cons that you should know about in the esophageal uh, topics. Okay.
Okay, thank you very much. Thank you.
Thank you, sir.
Thank you.
Thank,
Thank you, sir.
thanks.